Hello everyone. Today we will discuss about an important topic in examination, an important topic in clinical examination, that is pulse. So as we know, when we start clinical examination in vitals, first thing we observe for is about pulse. So you all know that there are some components. Before that we will discuss about the definition of pulse, which is asked commonly during Viva. So pulse is nothing but a waveform. It is a waveform which is felt over an artery. So waveform felt over an artery because of elongation and expansion of that arterial wall. So elongation and expansion of arterial wall. And this elongation and expansion is occurring because of changes in pressure during ventricular systole and diastole. So this is the definition of pulse. To understand it properly, we know that left ventricle will be contracting during systole, and the pressure generated during that is about 120 millimeter of mercury, and it will relax during diastole, and pressure will be 80 mmHg during that, which we commonly measure. So this outlet from the aorta, we will be feeling the pulse over an artery. Commonly it will be radial artery or carotid artery. So whatever the feeling which we are able to perceive because of these changes in the ventricular pressure during systole and diastole, so when it comes, there will be expansion and elongation of the artery. So this one we are feeling, that is nothing but pulse. So it is a waveform felt over an artery because of elongation and expansion of the arterial wall that occurs because of changes in the pressure during ventricular systole and diastole. So this is the definition which we have to understand. Now, so this waveform we have to draw. So what we will feel is normal pulse waveform is like this. So there is when there is systole, and when it pumps blood into the aorta and arteries, it is called as percussion wave. So it is pumped out, which we are feeling now. So the pressure increases, and after that pressure will fall. So there will be a fall. But once it pumped and once ventricle pumped and blood went into the peripheries, pressure raised, and immediately there will be fall of pressure, that is nothing but notch. And when the pressure is falling, immediately we know that the semilunar walls will close. So this will close, and whatever it is coming back, that will be reflected here. This is one thing. Second one is, we told that after pumping here, it will reach the peripheries. Where there will be junction of artery and veins. So at this junction, there will be capillaries. We know this thing. So here will be the resistance by this peripheral vascular system. That is nothing but peripheral vascular resistance. So because of this resistance, whatever the blood is reaching will get reflected back to some extent. So this reflected wave and the wave generated because of the closure of the semilunar wall, both of these will interact, and there will be again a positive pressure. So that will again be reflected as small second wave. So this is normal pulse waveform. So this will be very small. Now we will label it. This normal waveform is called as catacrotic pulse. So normal pulse is named as catacrotic pulse. And coming to the waveforms, we told that this is because of the ventricular systole. So this is called as P wave, percussion wave. Then there will be a notch. So we label it as N, the dip. So immediately after dip, there will be again a positive waveform. That is because of the interaction of wave which is reflected from the periphery and the wave which will be repercussed because of the closure of semilunar walls. So this is called as D, that is dicrotic wave. So there are three terminologies. One is percussion wave. Then there is dicrotic notch. Then again a second small positive wave, that is dicrotic wave. So P and D. This we have to remember. P and D are the components of waveform of a normal pulse. So this is about the introduction. Now we will deal the components which we will examine during pulse. So the components are like this. First is we look at the rate of heart rate, that is pulse rate, then rhythm, then character of pulse, then any delays, radio radial or radio femoral delay. Then we will examine for the vessel wall character, and finally whether all the peripheral pulses are felt or not. So peripheral pulses. So this is a pattern we will follow. So we will deal one by one now. In rate, we all know that we will use 3-finger method to examine pulse. So in that we will be counting the number of pulse in a minute. So we will get usually 60 to 100 beats per minute. This will be the normal rate. So if it is less than 60, we consider it as bradycardia. More than 100, it will be tachycardia. Coming to rhythm, when we are feeling the pulse, we have to observe whether the beats are coming at regular intervals or not. That is rhythm. Normally it will come at regular intervals. Here clinically few things are important. One is regularly irregular pulse. One more is irregularly irregular. This probably you all know. Irregularly irregular. The rhythm will not be expected at a regular interval. So this will be irregularly irregular. Common cause for this will be atrial fibrillation. Other than that, if there are any extra systoles or atrial flutter with variable block. So these are few conditions. Coming to regularly regular. For example, we are feeling the pulse and it will be like there will be either skip or some missed beat at some regular intervals. For example, ventricular bigeminy. Here, when we are feeling pulse, there will be first normal wave. After that, immediately there will be early contraction, early stimulation of the ventricle. So that wave will be felt immediately after the normal wave. Then there will be a pause. After that, again there will be normal wave. So to draw it, suppose there is normal wave. Immediately after that, there will be one wave, which is nothing but premature contraction. So we can consider it as a form of PVC, premature ventricular contraction. So that will give a wave which is not expected immediately after that normal wave. So because of this premature ventricular contraction, there will be compensatory pause. So this pause will be more than the expected one. So after that, again we'll get normal wave or normal pulse, immediately followed by premature contraction. So this is called as bigeminy. Similarly, trigeminy and atrial flutter with fixed block. These are some reasons. Ventricular trigeminy and atrial flutter with fixed block. These are the reasons for regularly irregular pulse. This is about rhythm. Coming to the character, which is very, very important for Viva. We told that normal character of pulse is named as catacrotic pulse. That is normal. We have to deal with some abnormal characters of the pulse. For this, first of all, commonest artery palpated is carotid artery. Carotid artery for the character of pulse. So we will deal the abnormal pulsation. After that, we will come back to the further details of pulse. So we know that normally, there is a percussion wave, then there is notch, then there is dichrotic wave. So this is P, N and D. This is a normal waveform, which is called as catacrotic. And you know the mechanism. Percussion will be the push by ventricular systole, which is felt at the carotids. Immediately after that, there will be fall of pressure, so there will be notch. And when the pressure is falling, semilunar valves will close because of that reflex waves and the reflected wave from the peripheral vascular resistance. Both will interact and give another positive wave. But when you are feeling at carotid, this is so small that we will not be able to make out. That's why when we are feeling carotid artery, we will be able to feel only one upstroke or one positive wave. That is nothing but percussion wave. So this D, dichrotic wave, will be very subtle, so that we will not be able to appreciate normally. Now we will deal with some abnormal pulsations. First one is pulsus parvus et tardus. Parvus tardus. So to understand the meaning of this terminology, parvus is small, tardus is slow. So pulse is small in amplitude and it is very slow. And to draw this, first we will understand why the pulse is small and it is slow. As we know that here, so the ventricle is pumping the blood into the aorta, right? So this is aortic wall which has to be open during ventricular systole. So it will be able to easily pump the blood out. That will lead to percussion wave. This is normal thing. Now we are saying that this percussion is not to the amplitude which is expected. So the amplitude is low. That is nothing but it is pumping the blood, but there is some obstruction. That's why it is not able to generate that amount of pressure. So this is nothing but aortic stenosis. That's why it is though the ventricle is pumping, because of obstruction, it is a small wave and it is small and it is taking longer time. That is slow. Similarly, the next wave will be small and long. So here if we want to conclude that, we can draw like this. So it will be small and it will be long. Small and a slow one. This is pulsus parvus et tardus seen in aortic stenosis. Okay. Next abnormal character of the pulse is pulsus bisferens. So pulsus bisferens. First we'll understand what is pulsus bisferens. So in the name itself we can remember bis will indicate both in systole. So there are two waveforms generated in systole. Normally we know that in systole there will be only one percussion wave. The other one is not felt because it is very subtle. But here abnormality is that we are able to feel two pulsations in systole. So we will understand the mechanism first. So here again if we want to draw, so we know that in systole ventricle is pumping out the blood and it is generating a wave. Okay, but what is happening here is, as the ventricle is pumping out, in between, that is during mid systole, there is this obstruction. Initially it was not there, so it was ready to pump and it has started pumping. So we got a wave, but in between, that is in mid systole, this obstruction has started. That's why the ventricle is pushing again hard. That will reflect as a second wave in systole itself. Mid systole obstruction. Okay, that's why it is appearing as a two wave. This is called as bifid wave. So when we are feeling this pulse, there will be two upstrokes during systole. This is the importance. So where do we get mid systole obstruction? When there is aortic regurgitation plus aortic stenosis of moderate degree. So to understand this, see, in aortic regurgitation, when the ventricle is pumping the blood out, it is being pumped with very high pressure, right? So we are getting a positive wave. But this patient is having associated moderate aortic stenosis. So when it is contracting, there is mid-systole obstruction. That's why ventricle has to pump harder to empty itself. That's why there is a second positive wave. Similar thing will occur in HOCM. So in HOCM, we know that initially the ventricle will pump, but during mid-systole, that obstruction will be significant. That's why ventricle has to pump harder again, which will be reflected as bifid or two waves in the systole. One more example is severe aortic regurgitation. Here the mechanism is little bit different. Severe aortic regurgitation, initially blood has been pumped out strongly, so that will be reflected but as a positive wave. But the thing is, immediately blood is coming back to the ventricle. So because of that immediate regurgitation, ventricle is contracting. It has started contraction and it is in the mid part of the systole. The blood is regurgitating back, so that will lead to the pressure in the aorta. So that will give rise to second percussion wave. So this is seen in only severe aortic regurgitation. We have to remember this. And we just now discussed that in aortic stenosis there will be slow and very less amplitude of pulse, but that is in severe. You have to remember this: severe aortic stenosis, severe form. When there is near complete obstruction, ventricle is struggling hard to pump the blood out. That will give rise to pulsus parvus et tardus. But here, when there is moderate aortic stenosis associated with regurgitation, now ventricle initially it will pump because the walls are open, but because of moderate degree of stenosis in between the systole, when ventricle size has reduced, obstruction will be prominent. That will give rise to bifid pulsation in the systole. That is nothing but pulsus bisferens. So to draw this waveform, we can draw like this. There will be percussion wave and significant second wave in the systole itself. After that, there will be fall in the pressure, that is notch, and again settle dicrotic wave. So overall, to draw it, it will appear as a three waveforms: percussion wave, regurgitant, or the second wave in the systole. There is fall, then a small dicrotic wave. So this is bifid. So both are in systole only. This we have to remember. Coming to the next one, just little bit contrast to bisference is dicrotic pulse. Dicrotic pulse. To understand the terminology, we have used dicrotic word when we are describing D in normal waveform. Here they have given importance to dicrotic, so that itself will suggest that this D wave is significant here. So we'll understand that first. Here what is happening is, when we know that dicrotic wave is generated because of the interaction of two waves. One is because of closure of semilunar walls, and one more is the reflection coming back because of the peripheral resistance. So both will interact and give rise to a small positive wave. Now we are telling that this subtle dicrotic wave, which was seen in normal pulse, is significant. That will suggest the interaction pressure is more than expected. So we'll deal now. It has pumped blood into the peripheries. So the waveform will be reflected back here because of closure of this. This will be reflected and this will give rise to dicrotic wave. Now we are telling that this is significant. So in what condition it will be significant? When there is decreased cardiac output, when the heart is not pumping enough blood. So during that time, peripheral tissues will be having vasoconstriction. So there will be vasoconstriction, and because of that, resistance will increase. So that will be reflected as a significant back wave. That will lead to significant dicrotic wave. So this is seen in some conditions such as congestive cardiac failure, when the heart is not able to pump, or there is hypovolemic shock. When there is decreased volume in the body, peripheral tissues will not get that amount of blood. And they will say in sepsis also we can see this dicrotic wave. We might think that in sepsis there will be decreased peripheral vascular resistance because of vasodilation. But the thing is, that will be the initial compensation. So initially peripheral tissues will have vasodilation so that they will get blood, enough blood in sepsis. But the thing is, as the severity increases, mechanisms will fail, so that later the body will think that only the important organs should get sufficient blood, so that there will be again vasoconstriction. So that will give rise to increased peripheral vascular resistance. That will give rise to significant dicrotic wave. This is in sepsis. And in cardiac tamponade. Cardiac tamponade. So there is a pressure from outside, so that the ventricle will not be able to pump enough blood to the peripheries. Again, peripheries will get vasoconstriction and increased vascular resistance. That will give rise to significant back wave. So dicrotic wave. So to draw it, there is percussion. There is percussion wave, and after that there will be a big gap, and there will be a dicrotic wave. So percussion wave, and so to see the difference here, when we are feeling carotid artery for the character, we will be able to make out two pulsation immediately in case of pulsus bisferens. Whereas when we are feeling the pulsations, there will be two positive forms, but one will be in systole and one will be in diastole. So for that we have to feel the pulse and auscultate simultaneously. That is nothing but dicrotic pulse. So for this to remember, D for diastole. D for diastole. So the second positive wave will be in diastole. Here both in systole. This is the difference, and you know the conditions now. To list out here, we missed I think pulsus bisferens. So the conditions were severe AR or AR associated with moderate AS and HOCM. So just remember a term, mid systole obstruction. Coming to dicrotic pulse, where the heart is not able to pump enough blood. So this is seen in congestive cardiac failure, hypovolemic shock, sepsis, and even cardiac tamponade. Okay. Next abnormal pulsation is water hammer pulse. Water hammer or Corrigan's pulse or collapsing pulse. Collapsing pulse. These are the terminologies which will come together when we are dealing a condition that is nothing but aortic regurgitation or high cardiac output states like anemia, thyrotoxicosis. So here the thing is water hammer pulse. We told that when we feel for the character, we will be able to make out a percussion wave and there will be a fall. This percussion wave will be more than the usual in amplitude. So it will be like this. So usually it will pump out and that will be felt as percussion wave. But here the left ventricle is pumping blood to generate a wave which is more than normal in amplitude. So that will happen when there is more amount of blood being pumped. So this will happen in case of aortic regurgitation. The wave will be like this and like this. So it will be a tall, high in amplitude, positive wave. This is nothing but water hammer. So the mechanism to understand in aortic regurgitation, when ventricle starts contracting, it will pump the blood out. But the thing is, because of regurgitation, blood is flowing back to the ventricle. So at the end diastolic volume will be more than the usual. So because of this, the next pulsation will be more in amplitude. That is a simple mechanism. Now, to understand the differences between these terminologies, we know that in aortic regurgitation, one thing is it is coming back and the peripheral tissues, as usual, they will draw the blood which is being pumped out. So two things are happening, like both are taking away the blood. That's why the fall is so significant. The pressure fall is so significant. That's why it is called as collapsing pulse. It will immediately collapse out. So that will not be able to make out dicrotic wave at all because there is no closure of the aortic walls. Hope you got this point. Coming to water hammer pulse. So when do we call it as water hammer? There are some components. For example, when we are feeling for the pulse at the distal arteries, it will be high volume pulse. High volume. This is the first thing. Then when we feel for the muscles over that side, muscle knock will be there. Like the pressure will be too much that it will just hit the muscles also when there is a high pressure or high volume flow. So muscle knock will be there. This is the second one. And when usually we will palpate for radial artery. But in this condition, the pressure and volume will be too much so that even the pulses which are not usually felt so significantly will also be felt easily. Third component is smaller arteries should be palpable easily. And it should be collapsing in nature. Collapsing in nature. You might have seen or read that when we look for water hammer pulse, so the thing is we feel the artery here and usually we will be raising the arm above shoulder to feel for that collapsing nature. That is nothing but normally when there is a cardiac output or systole, blood will reach here and we will be able to feel for that. And the backflow will not be so significant. That's why the pulse, that whatever the flow will be there, will not be felt even we raise the arm. But in case of aortic regurgitation, the backflow, that is because of regurgitation, the backflow is so significant that the whatever the blood is flowing back will be felt even at the distal arteries. So that is nothing but collapsing in nature. So these are the four components of water hammer pulse. So we can consider that collapsing pulse is a part of water hammer pulse because we call it as water hammer only when these are the components. Why I am explaining this condition in detail is when there is AV fistula, for example, AV fistulas are there in the periphery. So we told that as the blood is pumped out, there will be capillaries and vein. So there will be some peripheral vascular resistance. But when there is AV fistula, this part of structure will be joined. That's why there will be arterialization of the veins. We can call that as. So the pressure or resistance will not be there. First of all, because of that peripheral resistance, it was like forming a back wave. Here, because of fistula, no resistance only. So whatever blood is reaching, it will immediately drag away the blood. So this is a condition in which again there will be significant collapse. So when the heart is pumping the blood, it is being drained out so fast. That's why it is called as collapsing. So what are the conditions and how to draw it? There will be pointed. See, the thing is, this word corrigan means pointed. So sharp, pointed, high volume pulse will be there in water hammer pulse. So condition is aortic regurgitation, and we told that if there is AV fistulas, it will collapse at the periphery faster. And the next abnormal pulsation is pulsus alternans. Pulsus alternans. So this is nothing but one wave will be stronger, second one will be smaller, weak, strong, weak. So alternatively it will be like that, seen in cardiac failure or LVF, left ventricular failure, where heart will try to pump. When it is able to pump it well, it will be a strong wave, and the next wave or next systole might be weaker one. So that will give rise to weak wave. So the volume will be changing. That's why it is called as pulsus alternans, seen in cardiac failure. These are some abnormal characters of pulse which everyone should know, and you should know how to draw the waveform also and the conditions with mechanisms. Here comes one important misnomer, that is pulsus paradoxus. Very favorite of examiners, especially for postgraduate exams. That is pulsus paradoxus. Many of you know the terminology and the mechanism, but we will discuss it shortly. Pulsus paradoxus. Here the thing is, when there is inspiration and expiration, like the changes in breathing, there will be some changes in cardiac output also. We know that during inspiration, venous rhythm will be good. Venous rhythm will improve, and the volume in the right ventricle will be more, and the right ventricle will expand to accommodate that volume, and it will pump the blood into the pulmonary circulation. This is a normal thing during inspiration. So right ventricular volume will increase and it will pump the blood into the pulmonary circulation. But in some conditions, what happens is, for example, if there is constrictive pericarditis and cardiac tamponade, or there is severe pulmonary obstruction. Okay. So in all these three conditions, during inspiration, venous return will occur as usual, but there is obstruction from outside for the expansion of the right ventricle in constrictive pericarditis and cardiac tamponade also. So to accommodate that venous return, this interventricular septum will deviate towards the LV side, because it cannot expand on the outward side. This septum will deviate. So then what will be the result? The LV volume will be low, decreases. So because of that, it will pump lesser amount of the cardiac output. So there will be decreased cardiac output, which will be manifested as fall in BP. That is systolic blood pressure. Normally we told that, and we know that during inspiration, there will be fall of systolic blood pressure. During inspiration, volume will be more, so that normal fall in the systolic blood pressure will be there. But here, significant. So when to consider it as significant? Fall of more than 10 millimeter of mercury in systolic blood pressure is significant. So if this is there, we call it as pulsus paradoxus. And why I told it is a misnomer, because here the things are related with blood pressure, but the name is given as pulsus. So it is not related to pulse, it is actually related to the blood pressure. This thing you have to know. Now how to measure this? So what we'll do, we will tie the cuff to the arm as usual, and we will be first measuring the systolic blood pressure of the individual, that all of you know. So once we get the recording of systolic blood pressure, deflate it. Now what we'll do is, we will start inflating the cuff. 20 millimeter of mercury more than the systolic blood pressure. Okay. Suppose SBP was 120, we will inflate to 140, and slowly we will start releasing the pressure. So as we release the pressure, we will be auscultating for quarter of sounds. So initially we will be able to make out some intermittent quarter of sounds. Okay. So you have to be observing carefully. So when we release the pressure, there will be intermittent sounds, quarter of sound. This will suggest the SBP in expiration. As we release further, quarter of sounds will be continuous in nature, so it will be continuous quarter of sounds. This will suggest SBP of inspiration. So this difference you have to make out. Normally it will be less than 10 millimeter of mercury. So if it is more than 10, you call it as pulses paradoxus. And we know that as we release the pressure further, there will be complete opening up of the artery. That is, like we will not be able to hear any quarter of sounds. That is, disappearance of quarter of sounds is nothing but diastolic blood pressure. That will suggest artery is being opened up. Okay, this is not required here. But the thing is, you have to focus here very carefully. So inflate some 10 to 20 millimeter of mercury above systolic pressure. Start releasing the pressure. You will be hearing intermittent quarter of sounds beginning. That will be the SBP in expiration. Next, the sounds will be continuous. That will be the pressure in inspiration. Calculate the difference. If it is more than 10, consider it as pulses paradoxus seen in these conditions. Here, one important thing to remember is, don't alter the breathing pattern of the individual. This should be measured in normal respiration, not like deep inspiration and deep expiration, because that will alter the pressures significantly. This is about pulses paradoxus. Coming to the other components which we listed out at the beginning is about delay. So delay. One is radial delay. So when we feel both the radial arteries at a time, there will be some delay, but it should not be made out by humans normally. If it is significant, it will suggest any embolism in the radial artery or aortic aneurysm or supravalvular aneurysm, supravalvular aortic stenosis. So these are some conditions which will give rise to delay. Coming to radiofemoral delay, coarctation of aorta might be the reason, or aortoaortitis of descending artery or descending aorta. This is about delay. Then we told that vessel wall character. See, normally when we are feeling the vessel or artery, it should not be palpable, normally. Just we will be able to feel the waves, but not the wall of the artery. So not palpable normally. If it is palpable, or if you can roll the vessel over the fingers, so rolling over fingers, it will suggest patient is at risk of developing atherosclerosis. You have to remember this. Normally the vessel wall will not be felt. If it is felt and if you are able to roll it around, then it is a feature that patient might get atherosclerosis. This is about vessel wall character. And at the end, you should be able to feel for peripheral pulses like dorsalis pedis mainly. So normally these pulsations will be felt. If it is not felt, then we have to consider some conditions like congestive cardiac failure, left ventricular failure, hypovolemia. So in these conditions, there will be the peripheral, or if there is some local obstruction in that particular vessel, it will not be felt. So this is about pulse examination. And few things which we missed actually in the beginning is pulse apex deficit. So when you get irregularly regular pulse, and when you consider commonest cause as atrial fibrillation, you have to measure pulse and you have to count the number by using stethoscope at apex. If the difference is more than 10, it is suggestive of atrial fibrillation. This is one point. And we missed volume of pulse. It is mainly decided by pulse pressure. So pulse pressure is equal to systolic blood pressure minus diastolic blood pressure. So normally 120 minus 80, it will be 40. To mention the range, it will be like 40 to 60. 40 to 60 is normal pulse pressure. So if there is less than 40, it is low volume. If more than 60, it is high volume pulse. So again, you can consider it as a misnomer because volume is decided by pulse pressure. And as you practice, you will be able to make out whether the volume is high just by the feel. before measuring the pulse pressure. So high volume will be like bounding and low volume will be like jerky 3D pulse. So these are the things. I hope you got the points. So to revise shortly, we dealt about rate, rhythm, mainly irregular rhythm is significant. If it is there, look for pulse apex deficit, then volume, after that character and the carotid artery, various characters, reasons for that, mechanisms and the waveforms we should be able to draw. After that, vessel wall, character, then radio-radial delay, radio-femoral delay, and whether all the peripheral pulses are felt normally or not. This is a detail about pulse.